Thank you so much, Violetta. Thank you for a kind introduction and good morning, everyone. It's nice to see so many here this morning. Maybe we will be some more when the morning goes on. And the topic we are exploring today is lifespan after MBS, a multidisciplinary patient-centered approach. And this is an important and evolving area of care that brings together different disciplines with one shared goal: improving long-term outcomes and quality of life for patients. And today we will focus on how a collaborative, patient-centered approach can support individuals throughout their journey after surgery. This includes not only medical and surgical follow-up, but also psychological support, nutritional guidance, and adaptation with health-related behaviors. A key part of this journey is physical activity. Movement and exercise play a crucial role in recovery, long-term weight maintenance, metabolic health, and overall well-being. And today we will explore how to safely and effectively integrate physical activity into long-term care after bariatric surgery, tailored to individual needs and capabilities. We look forward to an engaging and insightful discussion with all of you, and we hope you will leave with practical knowledge and inspiration for your practice. And I have nothing to declare. What is important to state that bariatric surgery is not an endpoint, but a tool in a long-term treatment journey. While surgery can lead to significant weight loss and improvements in metabolic health, long-term optimal outcomes depends largely on what happens after surgery. Ongoing follow-up, behavior change, and continuous support are important. The focus should always be on sustainable health. Obesity care also needs a lifelong patient-centered perspective. Each patient has individual needs and goals, and these can change over time. That means care must be flexible and continuously adapted. When we keep the patient at the center, we improve engagement, motivation, and long-term adherence. Maintaining results requires structured support for key health behaviors: nutrition, physical activity, sleep, and mental well-being. Behavior change is complex and requires ongoing professional and social support. In the end, long-term optimal outcomes after surgery is shared responsibility built on continuous integrated care. After surgery, long-term health is strongly influenced by several factors. However, everyday behaviors are important. Physical activity plays a central role, not only structured exercise, but also daily movement. It supports weight maintenance, preserves muscle mass, improves physical function, and enhances quality of life. Physical activity is a key driver for long-term health and affects eating and nutrition behaviors, sleep and recovery, and mental and emotional health behaviors. Patients with obesity should always be seen as active partners in their own care, not passive recipients. Their engagement is central to long-term outcomes. This requires close collaboration across professions, including surgical, physiotherapeutic, exercise science, dietetics, psychology and behavioral medicine, as well as primary care and structured follow-up systems. When these disciplines work together in a coordinated way, we can provide more consistent, patient-centered, empathetic support that improves long-term outcomes. In this workshop, we will explore the integration of evidence and clinical experience. We will discuss practical strategies to support health-related behaviors and consider how these can effectively be implemented in real-world settings. A key focus will be on how different disciplines can work together to improve outcomes through collaboration. Throughout the session, we will also emphasize the importance of keeping the patient perspective at the center of care and decision making. So today's program focuses on health-related behaviors as core component of care after surgery, and we will begin with a presentation on nutrition, sleep, and exercise after surgery, offering an integrated approach to these key health-related behaviors. And the presentation will be held by Lucia Alonso, who is a registered dietitian nutritionist working in the endocrinology and nutrition department at Hospital Clinic Barcelona, Spain. She is currently pursuing a PhD in nutrition at the University of Barcelona with a research focus that is so important for this session, a patient experience and empowerment in obesity care. Her work integrates evidence-based nutritional strategies within a multidisciplinary approach to obesity as a complex and chronic disease. Through both her clinical practice and research, she aims to contribute to more compassionate, stigma-free, and personalized care pathways for people living with obesity. And the next one is Professor Dr. Manuel Pinolo, and he will talk about from theory to practice, designing and progressing exercise programs before and after bariatric surgery is the title. And he is a specialist in exercise science and obesity. He holds a degree in physical activity and sports sciences. He's an author of the upcoming national guidelines of the Spanish Society for Bariatric and Metabolic Surgery, contributing to a chapter on exercise and bariatric surgery. He's also a member of the Spanish Society for the Study of Obesity, the European Association for the Study of Obesity, and the Spanish Society for Bariatric and Metabolic Surgery. He's also involved in the International Federation for the Surgery of Obesity and other therapies for obesity. He's currently conducting research in the Department of Physical Activity and Health at the Pablo de Olavide University, developing a clinical trial on physical exercise and bariatric surgery at Virgin, I'm sorry if I'm not saying that correctly, Del Rocío University Hospital in Seville. He has extensive clinical experience in healthcare settings focused on exercise and bariatric surgery. So this session, I hope, will bring us together around these important topics of health-related behaviors from different perspectives. I'm really looking forward to your presentation, and I think I move it over to you, and thank you for myself so far, but we will stay here. So, welcome, Lucia. It's your turn. Yes, you are welcome to take this. Okay.
Yes? Oh, it's working. Thank you. So thank you so much, Lisa, for the kind introduction, and also thank you so much for the organizing committee for inviting me to this workshop on lifespan after bariatric surgery. And the topic of today, I think that it's really important also for my career, as it is the some lifestyle factors that are really important after bariatric surgery, which are nutrition, sleep, and exercise, all integrated in an integrated approach, as no lifestyle factor works better than all together. So I hope you have slept well. So I have the full attention for this presentation. I have no conflicts of interest to discuss. So as Lisa said, bariatric surgery is currently one of the best tools for the sustained weight loss, and also for the remission of obesity related to comorbidities. But as we know, obesity is a chronic relapsing disease, and recurrent weight gain is well documented over time after bariatric surgery. So some studies suggest that around 20 to 30% of patients experience recurrent weight gain after bariatric surgery. Obviously, depending on the definition that we use, but the IFSO published a consensus on 2024 defining this recurrent weight gain as more than the 30% of the initial surgical weight loss, or the recurrence of obesity comorbidities. Some behavioral factors and lifestyle factors are the most important contributors, modifiable contributors of this recurrent weight gain. And this is what we are going to talk about today. And so is that the Canadian obesity clinical practice guidelines illustrate this in this beautiful illustration, where they use the medical nutrition therapy and the physical activity as the basis where the tools for weight management stands. So I think that is important, but also the pillars of the lifestyle medicine, which are not only this healthy eating and physical activity, but we have more lifestyle factors that contribute also to this weight and this weight gain, and also to these healthy habits. And lifestyle medicine is an evidence-based practice which uses these lifestyle factors to prevent and manage chronic conditions. So it's a good tool that we should use to manage obesity. So today we will focus on the first three: the healthy eating, physical activity, and sleep. But also stress management, social connections, and the avoidance of harmful substances are also important. But if there is one message that I wanted to really focus on today, is that no single lifestyle factor stands alone, and the combination of all of them is what works best for success. So just for an example, maybe you are experiencing now if you have sleep little today. So when we get poor sleep or sleep deprivation, the ghrelin levels increases with which is the hormone for hunger, and also the leptin levels, the hormone for satiety, can also decrease. This provoking also an increase of the caloric intake and an increase in the craving for energy-dense foods and also for palatable foods. And also this poor sleep can affect the motivation to do this physical activity, and also to have executive implications throughout the day. And on the other hand, another example would be that the regular physical activity also improves this sleep quality, and this sleep quality can also facilitate us to have high quality diet this also influencing on the activity as we get more energy and also high quality and good protein intake to be able to do this physical activity. So moving on to the first year of these three lifestyle factors, nutrition. After bariatric surgery, we have really important anatomical changes that influence our food intake that we will be talking about now in detail, which are some protein and vitamin and mineral malabsorption, also some gastrointestinal symptoms that we will see how they affect to our food intake. So one of the most prevalent challenges after bariatric surgery, nutritional challenges after bariatric surgery, are these nutritional deficiencies, but we have to take into account that there are also some pre-existing nutritional deficiencies that they must be addressed before this surgery so that we don't move on into the next phases of the bariatric surgery. So addressing these deficiencies is throughout structured nutritional care is a critical component of this comprehensive obesity management. And one of the most common or prevalent micronutrient deficiencies are vitamin A, thiamine, cobalamin, also vitamin C, folic acid, iron, and zinc. And we can see this in our work that was published by our team and Violeta Moise, where we saw the prevalence of these vitamin and micronutrient deficiencies. But I wanted to point out that we can see also these deficiencies in sleeve gastrectomy, which is sometimes associated with less deficiencies. So we have to take this into account also to assess these micronutrient deficiencies as well as in other techniques of bariatric surgery. And this is important because these micronutrient deficiencies can have serious clinical implications such as anemia, osteoporosis, and some neurological diseases. So for this nutritional management of the micronutrient deficiencies, it's really important also that we have this into account in sleeve gastrectomy also. We need lifelong monitoring and lifelong supplementation of these micronutrient deficiencies, but there is something important that we will talk about all this presentation, which is the adherence to these lifestyles factors. And some studies suggest that approximately over the 40 to 70% of patients are not adherent to these multivitamin supplements over the years after bariatric surgery. And some factors that influence this patient adherence are like the cost of multivitamin treatment. I don't know in your countries if they are supported by the government, but here in Spain we don't get this multivitamin supported with this cost. Also, forgetting to take these multivitamins. Sometimes the swallowing can be also a challenge. Also, there are some patients that lack belief in the benefit of this treatment and of taking these multivitamins. And sometimes the inadequate follow-up due to the missing appointments throughout the follow-up of bariatric surgery can be factors that influence this adherence to the multivitamin. So we need to simplify and personalize always our management with these micronutrient deficiencies. Also, we have to focus on this protein intake, on this macronutrient after bariatric surgery, as the combination of reduced food intake and also the impaired absorption and sometimes the intolerance to some protein sources can challenge this protein intake. And the international guidelines suggest the target of protein intake between 60 grams to 80 grams a day, or they are also extending it to 1 gram or 1.5 grams per ideal weight. But this target is sometimes challenging to achieve for our patients, as you can see in this paper that we published recently. And also because of this intolerance of the protein intake, okay, protein sources. So we have also in gastrointestinal symptoms which influence both this micronutrient intake and consumption, and also this protein intake. That can be vomiting, dehydration, also constipation, which can influence both micronutrient and protein intake. And I wanted also to point out one underrated, in my opinion, challenge after bariatric surgery, which is the change in taste that some patients experience. Most of it sometimes with the taste in red meat. So this also is a challenge to increase the protein intake throughout the day if we have some intolerance or changes in taste. And we could use also herbs and cooking techniques to improve also the meat tolerance, creating some sauces for the meat to be a little bit humid, okay? The long-term dietary strategy, as this workshop is on the lifespan after bariatric surgery, when these all gastrointestinal symptoms and also this intolerance are getting better throughout the years after bariatric surgery, we can experience greater hunger, and also we can shift from the habits that we were adherent throughout the first years after bariatric surgery, and we can move on to the consumption of more calorie dense or other foods, or maybe some ultra-processed foods. So this bariatric plate, it's a good tool also to, from one point, to increase this protein intake, but also to make sure that we have the satiety levels covered throughout the day, as we can get this 50% of protein, which will satiate throughout the day, and also this 35% of vegetables, increasing the volume of the plate, but without increasing the caloric intake. And also this part of 15% of carbs, complex carbohydrates, are also really important to maintain the overall satiety throughout the days. And as you can see, the 50% of protein, sometimes it can be difficult to achieve because of the issues I talked about before. So having more and different protein sources and having ideas to introduce these protein sources throughout the day, it's really important to achieve this protein intake target. So the long-term dietary strategy would be to eat protein first before these starches and carbohydrates to reduce this dietary drift. Also to eat a diet rich in fiber to manage this hunger that I talked before, and also gastrointestinal symptoms such as constipation. Also, hygienic and dietary measures such as small portions, slow eating, and also avoiding high fat and high sugar will help us with this satiety and with some gastrointestinal symptoms such as vomiting, constipation, dumping syndrome. Also, the two last points with meal preparation and enjoy food will help us to increase adherence to these healthy eating habits. such as weekly batch cooking, which increase good choices when we don't have so much time. And also enjoying this food can increase the adherence by the palatability of foods, and also to having more ideas to increase different protein sources. So this is why herbs and spices and different cooking techniques matter. So I hope to see you in the next session of culinary medicine, so that we can learn more about these 2 points. So now I will move on to the second year, that the sleep after bariatric surgery. I think that you maybe have experienced this, that this insufficient sleep affects also to this energy intake, such as craving more palatable foods, as I said before, and also the energy expenditure the day before, as we are more tired. And this may lead to a positive energy balance and also increasing the risk for weight gain or recurrent weight gain, okay? So I also wanted to point out this obstructive sleep apnea, which is prevalent in our patients and candidates to bariatric surgery. Some studies suggest the prevalence between approximately 40 to 70% preoperatively, even though after bariatric surgery, there are lots of patients who improve in this obstructive sleep apnea, but not everybody who has a good significant weight loss improve in this obstructive sleep apnea, which also decreases this sleep duration, also decreases the quality of sleep. And this is why it's also important, and also this obstructive sleep apnea has several implications also in some diseases, such as cardiovascular diseases. So this is why we have to take into account and also assess this sleep apnea. Do not make assumptions that everybody who lose significant weight loss will improve in this sleep apnea, okay? So the good part is that the sleep hygiene interventions are low cost, and they are evidence-based, and they have good patient acceptability. So one thing that we could do is encourage this sleep schedule and having the same time every night and morning, also during weekends. It's really important, this part. Also, something that we can also encourage are no screen minutes before bed, and we could replace this with reading or breathing and some mindfulness or meditation to improve this sleep. Also really important with the part of nutrition, we should avoid this late eating or these heavy and dense foods before eating. Also to improve and to avoid this reflux. Also having a good room temperature and a good environment, a dark environment, should be also important. Some other things that we could apply in our clinical practice are the cognitive behavioral therapy for insomnia, which is the first line for chronic insomnia. That could be also be done by digital delivery. And also another thing, it's the Pittsburgh Sleep Questionnaire Index. I don't know if you know about this questionnaire, but it's to assess this sleep quality, and it's easy to do also, and it's fast to do maybe in our clinical practice, okay? So moving on to the last year, the exercise after bariatric surgery, I'm sure that Manuel will explain to us much better than I, but I just wanted to point out some brief points. It's really important that when after bariatric surgery, there is a huge weight loss, but not only from fat mass, but also this lean mass and muscle mass. So we have to move from the idea that physical activity is for calorie burning, but from the lean mass preservation, because this has several clinical implications. When we lose this lean body mass and muscle mass, we can increase the risk of having sarcopenia, and also the loss of bone mass. And this has several implications in the increased risk in diabetes and cardiovascular diseases. Also, the impaired function to make physical activity. This is why also it's important to assess and to manage this lean body mass decrease, and also the weight cycling with the reduced resting metabolic rate by the decrease in this lean body mass. So just to point out some clinical practice guidelines from the physical activity after surgery, it is important to increase mobility and also to enhance this mobility after bariatric surgery. First walking, and then moving on to more resistive exercises, and the abdominal exercises or core exercises should be encouraged throughout the third month after bariatric surgery. But this should always be encouraged by a professional that also give us advice on how to make this physical activity, so also that we don't harm ourselves making this physical activity, that sometimes patients are worried about this. So some tips that we can get to increase this exercise adherence after bariatric surgery, or also for our patients with obesity, is to set specific and personalized goals. Also, some patients in our clinic also look after having group work, also with walking in groups, can also increase the commitment. Enhancing also intrinsic motivation and autonomy, and addressing the ambivalence toward this change is also really important, as throughout also motivational interviewing techniques to increase this adherence and to promote this patient-centered approach. Also, identifying barriers and planning solutions for these barriers, it's really important, because sometimes our lives are different and we may have different barriers, and the best personalized and planning this solution would increase the adherence also to do this physical activity. Also, the ongoing contact and the follow-up of the physical activity is really important, not just recommending and setting these goals in the first session, but to continue working on that throughout the sessions and from the visits. And also, the last point I wanted to point out is to tailor the intensity and type of individual needs in the physical activity, not just recommending and telling people what they have to do and doing more exercise, okay? So I'm reaching to the end of the talk, but I wanted also to point out the importance of this multidisciplinary team. I really like this illustration where we can see here the patient and family in the center of the team. But also we have different chefs, physical activity specialists, we have nurses, a registered dietitian, and I am really sure that there is still left some professionals also in this illustration. But an effective obesity management requires a patient-centered approach grounded in this multidisciplinary collaboration, so we increase this success in this management. Also improving the results pre and post bariatric surgeries. Some additional components, I don't know if we see it here in the illustration, but support groups also improve adherence after bariatric surgery. Flexible care models increase access, and also because we sometimes we are not able to have all these professionals in our multidisciplinary team, but referral networks fill these gaps in our care and management. So I wanted to, before I move on to conclusions, I wanted to point out 3 things that we can start doing different tomorrow, that independent on the resources that we have. One of it is the screen this sleep during our visits, and we must ask our patients how they are sleeping and address this consequently to better also manage other lifestyle factors as nutrition and physical activity. Also, really important to assess the protein at every consultations. We can do it by 24-hour recall, different targets, but we should find the specific barrier to this protein intake. If it is the tolerance, the access to protein supplementation, the cost, or the knowledge about which are the protein sources. And we should address it and not just recommend it to eat more protein. And the last of these 3 things to do different is to prescribe this exercise. We should prescribe the type of exercise, the frequency, the intensity, and also the progression. That is really important, and not just living in the same exercise throughout all the years. Okay, so we should treat it in the end as a medication also, and doing follow-up throughout the visits. So just moving on to the last take-home messages that I wanted to, that you went home with these messages, is that obesity requires a sustained, integrated, personalized, and compassionate approach to the behavioral and lifestyle factors with the patient in the center of the management. Also, physical activity is not optional, and it's the mechanism throughout which muscle is preserved, and also to help us throughout different lifestyle factors. Also, lifestyle medicine, including sleep, physical activity, and nutrition, are more powerful than any other of them alone. So we will have more success if we address all of them and not different lifestyle factors in isolation. And as healthcare professionals working in these fields, our role is to be evidence-guided and patient-centered, and not judge our patients, but giving tools to increase this adherence to lifestyle factors. Okay, so thank you for listening, and I'm open to questions. We will do the discussion later, Lisa, or
let's see. Do you have any question? Do you want to take question now, or we can discuss? Okay, go ahead. Yes. Oh, there's a microphone. Yes. Okay. So if you want to introduce yourself, since we are going to be here the whole day together, I hope so we can get to know each other a little bit more.
yes.
But I just don't know if it's working.
Oh,
Probably
is
not.
it?
No?
Oh,
I'll
let
get help.
me make sure. Good. Then we take 2 questions on that.
Let's see. Oh, I think
Yes,
it is.
great. Thank you.
Thank you, Lucia, for such an incredible presentation. So important.
Thank you.
My name is Danielle. I am a clinical psychologist. I also work in an MDT bariatric service in the UK. And we have indeed been paying more attention to what impacts adherence to nutritional bariatric guidance after bariatric surgery, also from a psychological point of view. And I don't know if you noted in your research any psychological factors that also impact on how they comply with the guidance. For example, we are now paying more attention in different centers in the UK to neurodivergence and ADHD. There is some information that I think patients with ADHD may find it harder to comply or to adhere to the post-op plans because having a structure repeating. So we are now also paying attention to the differences from people on ADHD medication or without ADHD medication, and when the medication is introduced after bariatric surgery, if that also impacts on the adherence, because they need to cope with many changes. So I don't know if there is anything in terms of the psychological aspects or neurodivergence that you also noted. Sorry.
We haven't looked up to, thank you for your question. We haven't looked for this neurodivergence aspect. I don't know if our psychologist maybe is working on that, but I think one of the most common also psychological aspect in our clinical practice is usually the anxiety, and also we found this and also sometimes depression also. We find this challenging for this adherence to this physical activity, also with this nutritional management, with this emotional eating that also increases this calorie intake and palatable foods. So I think that this is also a really, really important lifestyle factor. This wasn't the target of today, but it is also a lifestyle factor in the lifestyle medicine, the stress management, and I think that is really important that we should address it also, because if not, we will be lacking something to work on nutrition and also physical activity. Thank you. Okay.
Any other question for now, or we move on to move our skeleton, or not yet, Manuel? Are we moving? We want to move, I guess, right? But okay, we can wait. Everybody has her bands, because their bands, I know some people came in right now, and I'm not sure if they have it. Otherwise, are in the back. Okay. So, hold yours. Otherwise, I keep.
Sí, creo que sí. Al revés, creo. Sí, porque va encima la oreja, exacto. Así, perfecto. Vale, y esto no sé. ¿Me llevo así? ¿Tienes un
Sí, cojo este, ¿no?
Thank you.
Okay. Yeah. Okay, hello. Okay, good morning, everyone. Okay, thank you very much for the invitation. It's a pleasure to be here today. Sorry for my English level. My name is Manuel Pinelo. I'm from Seville, it's near to Malaga. And today I will talk about exercise and bariatric surgery, and how can design and progress exercise program before and after surgery. This topic I really love. I working in this topic from 2019. Okay. I would like to thank you, the organizers, and all collaboration involved in this work, and I have no conflict of interest. Bariatric surgery is one of the most effective treatments for obesity. It helps patients lose weight and improve their health. However, long-term results very variable. Exercise is usually recommended, but in many cases it's not well individualized. And today I want to focus on this problem. About me, in my background, these are the objectives of this workshop. We will talk about muscle, bone, and functional capacity, preoperative and postoperative exercise, how to assess physical function, metabolism, and how to prescribe exercise in a more precise way. In the final, we did a little quick exercise, so you have to listen, okay? About me, my background, I'm a clinical exercise physiology. I work in a metabolic unit and in cardiac rehabilitation in Seville. This picture is from cardiac rehabilitation. I'm also conducting a clinical trial in bariatric surgery at Hospital Virgen del Rocío, focused on exercise and metabolic response before and after surgery. There is a problem after bariatric surgery. Patients lose weight, all the people know, but they also lose muscle mass. They lose bone mineral density and their functional capacity decrease. Also, exercise is not well individualized. After bariatric surgery, muscle mass starts very early. In some studies, patients lose a significant muscle in the first week and months. This is very important because muscle is key for strength and daily function. Studies such as BAUS show weight loss of 20.3 kilos 3 months after the intervention. 16.4% was muscle mass. It's very high, okay? Leg width showed with DEXA muscle weight loss of 20.4 in 6 weeks. The greatest percentage of muscle mass loss occurred in the first few months after the intervention. We should not focus only on muscle mass. We should focus on strength and function, because function is what really matters for the patient. We are not only helping patients lose weight, we are helping them improve their quality of life. Patient lost bone after surgery. In this picture, you can see 2 different surgeries and the percentage of loss. This happens especially in the first year. In some cases, bone loss can be significant, and in the long term, there is a higher risk of osteoporosis and fractures. In this retrospective study with 249 patients, significant decline in bone mineral density during the first year after sleep. In this study, you can see 10 years after bypass, 27% of postmenopausal female were osteoporotic. The prevalence of fragility fractures was high. As shown, bone mineral density decreased after bariatric surgery. The question is, why does this happen? Mainly because of reduced absorption of nutrients and reduced mechanical load. Less weight means less stimulus for bone. So the question is, can we prevent or reduce this loss? Well, we know that obesity can prevent osteoporosis, but not always. If obesity is defined of the basis of body mass index or body weight, it appears to protect against bone loss and fractures. However, if obesity is based on percentage of body fat, it may be a risk factor for osteoporosis. in clinical practice, we can see this change using DEXA. We can observe bone loss before and after surgery. Sometimes in my clinical practice, we see bone mineral density like that, pre-surgery, or like that. So this patient have problem pre-surgery in bone mineral density loss. Here you can see the lost bone in 5 years after bypass and how bone mineral density decrease in different areas. Another important problem is exercise prescription. This is a very hard image. You can see different areas how to lose bone mineral density. So for that reason, exercise is very important. Exercise is not an accessory, it's a treatment. In this systematic review, show that exercise interview after bariatric surgery are poorly reported. These findings highlight the urgent need to improve both exercise prescription and reporting quality. So after surgery, functional capacity decrease. Patient may have difficulty with daily activities like walking or standing up. VO2 max can also change, but it's not always easy to interpret after weight loss. So we need to better assessment tools. After surgery, absolute VO2 max tend to decrease, whereas VO2 max adjusted for body weight improves. Preoperative fitness is very important. Patients with low fitness have more complications during surgery. So improving fitness before surgery can improve outcomes. The goal of cardiovascular training is to improve cardiorespiratory fitness. This includes VO2 max, ventilatory threshold, and efficiency. Okay, how to evaluate physical function? We need to assess functional capacity. We can use simple tests, hungry strength, 5-time child test, 6 minutes, or even only 2 minutes is enough. These tests are easy and very useful in clinical practice. And today I would like to prove. So 5-child test. The subject is initially sit in a chair and must stand up as quickly as possible 5 times. Here we can assess lower body power, and we are going to put in practice. Any volunteer here? Yeah. And Lucia, come here, please. Okay. We are going to do an example, okay? So sit down and yes. Okay, put your arm here, sit down. We are going to stand 5 times.
Okay.
We start sit down and finish sit down. Okay. We are going to say 3, 2, 1 and start.
Okay.
As quickly as you can, okay? 3, 2, 1, go. Okay, say the time.
8 seconds.
Okay. We are work in parts, okay? So now we are going to try on, or a small group, and use your mobile. Okay? Thank you. Okay. You can put the time in your mobile. Yeah. So we are going to start, okay? Okay, stop. I'm going to say. Yeah, okay. Yeah. 3, 2, 1, go. Okay, between 7, 10, okay? Between 7, 10. Okay. These are the average values, so you can see it depends of your age. You can here or here is very different, okay? Okay. Another test, hand grip. The patient will sit in a chair without arm and follow. We are going to do an example. Another person. Volunteer. Come here. Okay, sit down. Which do you prefer, left or right? Okay. Here. Put here. 3, 2, 1. Strong. Push. Okay. Very good. 15, 3. Okay, very good. And another. Yeah. 3, 2, 1. Go. Very good. A little more. Okay. Thank you. Another volunteer. Okay. Here. Okay, sit down here. You are which? Yeah. Okay. Yeah. 3, 2, 1. Go. Okay. 25. 3, 2, 1. Go. Okay. 26. Thank you so much.
So that's bad, yes?
We are going to see later. Okay. This is the R of the average. These are easy tests, and you only need 2 minutes for doing a clinical practice. So it's like the 5 squat, okay? Here we can assess cardiorespiratory fitness. It is a little more, you need more time. 6 minutes walking test in only 10 meters. But you can use another test in only 2 minutes. I would like to test, but not today, okay? This is the average value. So exercise before surgery has many benefits. It improves fitness and strength. It improves surgical outcome. And it helps patients follow the treatment better. So preparative exercise is very important. Exercise before bariatric surgery show evidence show low body weight, low waist circumference, improve 6 minutes walks, improve VO2 max peak. And after surgery, patients should start moving early. Walking can start the same day. A structured exercise program can start after the chair, usually after 1 to 4 weeks. In general, 1 month after. Exercise helps reduce complications and improve recovery. Start moving early and stay active. Progress gradually to aerobic and strength exercise. Follow-up and proper nutrition are key. Once we complete the initial assessments, the question is what to do, how much, when, and how. Everyone tells patients to exercise, but rarely provide clear and specific guidance. We can simplify exercise in 4 key movement patterns. Push, pull, knee dominant, and hip dominance. Okay, this is a mainly basic pattern. So if you hold your elastic band, okay, so come here, please. We can do a push and pull, for example, catch here, okay, and take for, okay, this is a push or pull? Pull, no? Okay, and you turn out and catch here, and this is a push, okay? So if you are alone, you can do, okay, it's not a best elastic band, but I can do.
One of the best.
Yeah, I know. Okay, see, thank you. Okay. For knee dominance, it's a squat, okay? And for hip dominance, is like a deadlift, this exercise. You can put your elastic band in your leg and you can open. There are a lot of exercise for that, okay? But the principal are the Fantastic Four, you know. This is an example you can use with elastic band, okay? Well, individuals with similar VO2 max can show marked different fat oxidation response. Not always the same value is the same. Metabolism is also important. 2 patients can have the same VO2 max but different metabolic response. So we need a more precise approach. We call this precision exercise. Same BMI can reflect completely different body composition, and the same VO2 mass can reflect completely different cardiorespiratory condition. For that reason, precision physical exercise is necessary. Even the same VO2 max can reflect completely different cardiorespiratory condition. For that reason, exercise is so important. Here you can see different age, same VO2 max, but different weight, sex, total watt, different ventilatory threshold. not all exercise are good for bone health. Bone need specific stimuli, high impact dynamic movement and varied direction, so exercise must be well designed to protect bone. Here you can see different exercise for bone health. This is an example. Another example, bone is a dynamic tissue that responds to change in a mechanical load by modifying its mass, structure, and strength. The main aspects to consider for bone development are intermittent dynamic load, rather than static load, high magnitude load applied rapidly, load applied in a unusual or diverse direction or pattern. This is an example for plyometric exercise for superior extremity. So what do we do in practice? We need a structured plan. Exercise should include strength, cardiovascular, and some impact work. And most importantly, it has to be individualized and adapted over time. Precision physical exercise is necessary. We are going to see a small video in a clinical practice from Virgen del Rocío in Seville.
Hi, my name is Juanma.
Hi, my name is Tamara.
We both have bariatric surgery. I have bariatric bypass.
And I have bariatric sleeve surgery.
We have the training for 8 months. And thanks to Manuel, we feel much better now.
Thank you so much.
We show some exercises.
Okay, you can see different exercise in different part of the body because you lose bone in different part of the body. Okay, so you have to do a plyometric exercise not only in the lower body. Okay, this is an example from an exercise program in a clinical trial we use. There are some exercise, time, week. It depends on the week of the exercise program. You do a specific exercise with more impact load or less impact bone. In general, we aim for 2 to 3 sessions per week, and the strength, cardiovascular, and also some impact work, depending on the patient. All the exercise can be 1 hour. You don't need 2 or 3 hours for that. And how do we measure intensity? We can work using a perceived exertion. If you feel it's so hard, it's not good. If you feel too easy, it's not good. Usually in the middle. But in the university, we use measure of each repetition through velocity of power. What means if you lose if you measure this, you can decide to stop the set when the fatigue is necessary, not too much. This is an example that we use. In the first months, we use in cardiovascular intensity MFO. This means maximal fat oxidation. And in strength program, we use 10% of loss of velocity. And we are going to increase the strength and cardiovascular training. We structure each of training over 1 year. We use velocity or power loss to decide when to stop the step. We are going to see a small video, and you can see this.
196.
176.
Stop. 3.
The patient no do more, because if you do more, you have more fatigue, and it's not necessary more fatigue. Okay. So we are going to do a small kicks exercise. Easy. Good, no? So, any mistake? Yeah. One mistake?
The first one.
One. 2 mistake? No. Okay. In conclusion, exercise is essential in bariatric surgery. It improves outcomes, reduce complication, and improve quality of life. We need a structured, individualized, and measurable exercise program. And thank you very much. And I will be happy to answer your question. If you need the reference, you can see here. Okay, all the reference.
Okay. Yeah, you have a question. You're welcome. Introduce yourself.
Thank you very much for the talk. So my name is Felicity. I am a dietitian working with Danny in a complex obesity service. We do bariatric surgery. We're quite new service, but I also am an exercise specialist as well. Within our service, we don't have any sort of physiotherapy yet. We don't have an exercise specialist. So I'm really intrigued by the talk and the potential within the service. With regards to the plyometrics, because they came out as being quite significant, the kind of rebound, those are done in a supervised environment, presumably with someone supervising them?
Supervising exercises, yeah.
So I think because doing those exercises obviously is high risk of injuring themselves. If we were to say to our patients to engage in that without the support, then we need to just be careful. So we need to direct them to somebody or create something.
Yeah.
Okay.
You have to start very easy, and you can to improve the intensity, repetition, bit a bit. No? Yeah.
Because they're obviously, and then hopefully in time they would lose weight and they would, their joints would be better as well. You know, it's that initial bit where they're not used to doing those exercises.
Yeah. For example, when we start a bone load, okay, we start in week in here. So the patient are training 12 weeks before to start bone load, right? Okay. So the patient start very easy and improve little.
Yeah.
Yeah.
So it's very structured, isn't it?
Yeah.
And one of my colleagues just asked what VO2 max was. So I just was aware that not everyone might know what a VO2 max was, and I just wondered if you could...
Sorry.
What VO2 max?
VO2 max, the number, say.
What is the definition of VO2 max?
VO2 max is the oxygen you use in your activity, daily activity, indefinitely. The patient in bariatric surgery has around 12, 20, and normal values is 41, 45, okay? And after bariatric surgery, the VO2 max tend to reduce. This VO2 max is an indicative of life. So, yeah.
Thank you.
Okay, next question. Yes, please.
Good morning. I'm Gas Garresti from Bilbao. Thank you for your presentation. I would like to ask you about the pre-operative exercise. How do you manage that? Because I suppose it's different from the post-operative.
Yeah.
So when you have a very low activity person, how do you manage that?
Yeah, the preoperative exercise sometimes is difficult because you don't know when the patient is going to surgery. Sometimes we need, or sometimes we have 2 months, 3 months. It's difficult because I don't decide when the patient go to the surgery. The main goals is preserve muscle mass, reduce body fat pre-surgery.
But have you got a specific type of exercise for those type of...
Yeah, you need to do a high exercise with big muscle mass, like press, pull, knee dominant. Okay. This type of exercise have more impact in the patient. Okay.
Thank you.
I wonder if we could show our colleagues the CEDO Go.
Yeah,
because
I don't
think it's there because it's a very practical way to communicate and to.
I don't have in this presentation.
No, I know, but I asked the helpers here to see if we could open the website as they would do on their clinics. Just to show them, CEDO is the Spanish Obesity Society, and with Manuel in. Are you in the group, right?
Yeah.
So they develop an amazing, what is that? It's like a app.
Yeah, in this app you can see different exercise for patients with obesity and even patients with bariatric surgery. Okay.
Oh, bariatric surgery. So do you have internet, like in the computer? Have like open it and.
Can we see? If you have it.
And to see, because we have some minutes left, it would be great if you take this with you.
I don't know.
Maybe we should not touch. It looks a little bit. But I have one question to you, if it's okay, Violetta, I ask. Yeah. Because I work very much with young people who want to do surgery.
Yeah.
And there we have sometimes a challenge that they want to wait until after surgery they start doing exercise. They say to us that, I start when I have done my surgery. How should we manage to communicate about importance of exercise even pre-surgery? Because it was very good. Your presentation was very interesting, and you highlighted very important aspects.
Thank you. Well, how to communicate? Last week we did an assessment in a patient in Hospital Virgen del Rocío, and in the last 2 days, a patient told me I had a ictus. Okay? So the communicate is this is so important for your health. You need to do exercise because exercise is not accessory. Exercise is a part of the medication, really.
Yeah. So it's not optional.
Yeah,
actually, it's part of the treatment.
This part of the treatment.
Yeah. So it's important to communicate at that level of importance of the activity. Yeah. Thank you. Any other questions meanwhile? Yeah, please.
So also on the back of what you just said there, what you were saying about the lower risk going through the surgery.
Yeah.
If you've done the exercise before.
Exactly. Yeah. So you lower your risk for complications during the surgery. Yes, that's a very important point. And of course, yeah, exactly. Yeah, they are. Yeah. So you just mention every aspect that could be.
We do that because we do the initial assessment, and you're always when we first meet the patients and we're talking about which treatment they might have. We always think about the long term, and actually, if you bring that in right from the start, then that's significant.
Yeah. So you start from the beginning and start talking about both benefits and also what maybe the risks if you don't exercise. Yeah, that's important. Yeah. Do you have something else you want? Please use the microphone so it's easier to hear.
Can you hear me? Yes.
Yeah.
It was very much just a thought in relation to what you said about your young patients. I'm a psychologist working with Felicity and Daniela in Colchester. And what I've seen with relatively young adults we see is the level of confidence is so low, isn't it? So psychologically speaking, I'm a psychologist. The barrier to, at times, go to the gym, go out there, is very much related to the stigma. So with some patients, I had to do a lot of pushing in terms of this won't magically change after surgery, and trying to prepare them for the fact that they need to push through the uncomfortable feeling on going to the gym, or anyway, exercising as they like. But when you exercise, your body's seen. So the gaze of the others, isn't it, becomes more present. So yeah, just is a very relevant point. Exercising before surgery is also psychologically complex, but to be aware of it is an important step as well.
Oh, thank you. That was very interesting. And you just highlight the importance of this multidisciplinary team, that we can use all resources in our teams, psychologists, dietitians, exercise specialists, and together we can improve the outcomes.
This is a web from CEDO. It's a Society Spanish of Obesity. The web is in Spanish, sorry. And you can see different exercise you can download here. You can choose lower on up body, full body, with more difficulty. You can see even the video. I don't know if you would.
This is not in English, no? It's only Spanish?
Yeah, only in Spanish.
Oh,
Sorry.
the Spanish is...
Yeah. No, not working. You can see here the different exercise,
Yeah.
yeah,
So
intensity, the mainly mistake. See everything, but sorry, only in Spanish. No, it's not open. Sorry.
Yeah. But it's good to know about this
Yeah.
page because...
Oh, okay, yeah.
Oh, no.
Yeah, I got.
Ejercicios con materiales. Remo con banda. Este ejercicio se centra en fortalecer la parte media y alta de la espalda. Activa de forma eficaz músculos como el dorsal ancho, los romboides, el trapecio y los bíceps. También es útil para mejorar la postura y contrarrestar la debilidad en la parte superior del cuerpo. Además, puede ayudar a prevenir molestias en la zona cervical y dorsal alta, reforzando la musculatura que sostiene los hombros y la columna. Podemos realizar este ejercicio sentados o de pie, con la banda elástica bien sujeta bajo los pies o en un punto fijo como una puerta o poste. Comenzamos con los brazos extendidos al frente y la espalda recta. Desde ahí, tiramos de la banda llevando los codos hacia atrás, pegados al cuerpo y juntando las escápulas al final del movimiento. Luego volvemos a la posición inicial de forma controlada, manteniendo siempre la tensión en la banda. Al realizar este ejercicio, es importante evitar algunos errores frecuentes, como subir los hombros o encorvar la espalda al tirar, utilizar solo los brazos sin estabilizar la espalda y el core, o generar tensión innecesaria en el cuello. Podemos introducir algunas progresiones. Una opción es utilizar bandas con mayor resistencia. También podemos realizar una breve pausa con los brazos flexionados y contrayendo el abdomen. Y si buscamos un reto mayor, podemos realizar la tracción en combinación con aperturas en cruz. Este ejercicio puede adaptarse fácilmente según el nivel de cada persona. Este ejercicio resulta especialmente útil en personas con espalda redondeada. Debe supervisarse en caso de lesiones en el hombro y no pasaremos a opciones más avanzadas sin la indicación de un profesional.
Okay.
Great.
Any question? No?
Do you have similar resources in your practices?
When you said about the loss of body mass, bone mass, and you said is it reverse? There's something about can you get it back? There was a question in there. So following on from doing your exercises, are we seeing then a rise that after the loss? We're seeing the rise. Thank you.
So when I say lost body mass, and repeat please.
And then after the loss, can we gain it again, or is it gone?
Yeah, it's usually when after, okay, you gain body weight. For that reason, the patient needs to a structure plan and win adherence. Adherence is the exercise, nutrition, and in multidisciplinary treatment.
And that's lifelong.
Yeah.
And as can we, if we, with people without bariatric surgery, if we lost some bone mass.
Yeah. Sometimes.
It's still hopeful.
Yeah. People who lose weight in the future, in general, gain weight because the body usually to come back to the last weight. No? So it's difficult. For that reason, it's difficult to do exercise. To do a program with very very long because the patient lost adherence and lost the goal. No? Yeah. Duration. we did a program with 12 months. 12 months. Because the bone, the change of the bone, you need time. Okay, in 2 months, you don't see any in bone. You need at least 6 or 12 months. Yeah, yeah. You can see a study put here with 5 years, no? If after 5 years, so for example, this one is after 1 year, those bone, and sorry. And there are another with 5 years after bariatric surgery, 10 years after bariatric surgery. You need time for see change in bone loss. Okay. Okay.
Okay, thank you. I think we all should raise up 5 times, up and down. So we have been sitting so long time. Yeah. Yes. It's stretching, but we have also questions to Lucia. Yeah.
Great.
And you can also be the. Maybe you need the microphone.
Oh, I can take this, or
can share this.
Yes, we can share it. Yes.
Yeah. Okay.
Well, let's clap. Thank you.
Yeah. We have clap our hands for both of you. Great. Oh, great presentation from both of you. Really, thank you. So now we have questions to for Lucia. Please, nutrition, sleep, and exercise was your topic.
If anyone has.
Yeah. Okay. I have about adherence to micronutrient supplements, because I think that's the difficult one to handle sometimes. As I said, I work with young adults, and as you said, it's not only them; it's all group, people who undergo surgery that have difficulties to remember or what it can be. But how could we improve the adherence?
Okay. Thank you, Lisa, for this great question. In our clinical practice, we use usually. One of the factors I talked about before was the lack of belief of the benefit from the multivitamin treatment, because sometimes we see that the analyses are okay, but as we see throughout the follow-up of the bariatric surgery, also the follow-up visits get less, and we see them throughout longer time. So some patients quit these multivitamin supplements, and then is where these analysis and deficiencies appears. So I think that one of the most important things also to empower these patients and to get active in their management of the obesity also is to increase the knowledge in this management, and also show them how these deficiencies affect their health also. And also from one part is to increase knowledge in these patients, and also sometimes one thing that in the support groups also patients tell us is that having alarms also, or reminder apps, they help them to remind of different supplements, because like for example vitamin D, that is sometimes 15 days between one dose and another. It's sometimes difficult to remember when you need to take these vitamins. So sometimes reminder apps or having a calendar might also help with this multivitamin supplement. So I will say both things, knowledge and also sometimes reminder apps. I don't know if... Also, yes, like having tailored products with a higher, also with all the multivitamin supplements, rather than having like calcium, vitamin D separately, all the vitamins separately, usually helps also patients. But for example, in Spain, it is supported by the government, only the vitamins isolated, the multivitamins, they are not supported by the government, and also having different forms of doses. Like sometimes patients don't have trouble swallowing these pills. So also having different forms of these multivitamins, like chewable or maybe effervescent. I don't know if it's in English. Like having different types of this multivitamin, I think that is also really helpful. Thank you.
Some other questions to see. Please, take a chance.
Thank you.
Hi, my name is Jan Mathé from Belgium. I'm a bariatric surgeon, but I also have a master degree in sports medicine, especially for the purpose of what you are all saying. And I appreciate it enormously that you are doing this, and I think it should be in the main Congress part, because it's so important. Especially, I can combine the both things, and I see a lot of colleagues of mine, for example, with weight gain, they are doing operations and again and again and again, and I don't think that's the right approach. On the other hand, it's just to remark this. On the other hand, question, we are also facing a very, very big challenge, especially with the anti-obesity medication. And I think all that we are doing concerning the physical activity and all the conservative programs, it has to be implicated also with the anti-obesity medication, and that will be a very, very big challenge. Also in my experience in the patients with weight gain, for example, I'm convinced that there is a lack of physical activity and compliance, etc. But nowadays they're saying, oh, but give me the syringe and we'll manage it with the syringe, and that will be a very, very big challenge, I think. Thank you.
Yes, I think that I'm really pro of empowering patients and make them an active partner in their treatment. That's why I'm always I always want for the patients to know about their management, and that's why I think that it's really important to show them how important is nutrition, physical activity, and other lifestyle factors to support their treatment, and rather than being a passive agent in their treatment, like only like having bariatric surgery or these obesity medications, like they need to be supported by these lifestyle factors, and not only in the early stages with like the weight loss with obesity medications and bariatric surgery, but it needs to be something throughout all the lifespan of this treatment, because it's a chronic disease. And that's why I think that having greater tools to increase this adherence is the most important. And for me, I think it's the challenge we are working on most, to increase this adherence so that we can support this treatment and have greater success. Yes, I think that it's a great challenge nowadays. Thank you.
Hello, my name is Maria. I'm from Russia. And last year we started the new type of bariatric operation. It's endoscopic sleeve gastroplasty, yes. And I have some questions regarding my patients. Is there any difference in diet progression for these patients, and also in physical activity progression? Thank you.
Okay, thank you. My colleague, Alba Andreu, is she's specializing in this type of treatment, and I don't want to tell anything that I don't know, but I don't know the progression of the diet, if it's different, or the physical activity, if it's any different for the endoscopic treatment. I'm sorry, but we could ask Alba Andreu that if she knows anything different.
Because there is no any information or consensus about these patients.
I don't think so, no, so we should work on that also, yes. Yes.
Okay. Maybe you can give her contacts to me. Yeah.
Yes.
Perfect.
And then we can lead initiatives that are for interest.
Yeah, because we do more or less the same as we do in other bariatric patients, but I think that is...
So take the opportunity, not only in the workshops, but also these days, to let us know what you expect or what you want to do from the integrated health in IFSO. We are welcoming surgeons in the integrated health, so we are so happy you're here. Any other surgeon, of course, here, another, this is growing and it's good. That's, you know, we want to focus on a transversal view of the sessions, and this is a transition, so it's great you are here. Thank you. And going back to your proposal, so this one is a very hot topic for us too. We are working on this. I don't know if you had the opportunity to complete a survey that we sent 6 months ago for all the delegates. Perhaps it went to your spam because it happens with the surveys we do. So we are very worried about this because it takes a lot of time to do a survey well done. The scientific committee review it, you know, it's a lot of feedback, and then people like you that are interested in doing things don't get it. So sorry about this. We are improving it too, but we need to learn about your needs and of course get involved in this work. I mean, you are going to do it, but we are going to help you, you know. So
thank you so much.
This is the idea, and the only way I think the integrated health, including surgeons, can grow within IFSO.
Because last year I had an opportunity to take a talk with Christine Stier.
Oh yeah, she's a nutritionist too. So this is great.
She talked me about this some points, but not all.
Okay, so thank you very much, and let's move forward. Are we closing? Do you want to say any? Oh, more questions.
Okay, but is there any more questions? Please. Some more? I think we are living interesting times. We have this bariatric surgery, anti-obesity medication, endoscopic procedures. So there is so much going on, and we need integrated health to support all these treatments so that we can improve for our patients in the long term. So that's a very good news anyway. I have a message from organizers, so please listen carefully. Please, we remind you to download the Congress app in order to scan your QR code and confirm your assistance. So please download the app and confirm that you have been in this session. I think it was mentioned.